All right, I have 6:30, time to start. Good evening. My name is Dr. Southern, and I thank you for joining me this evening. I'd like to talk about alternatives to surgery and does your joint pain really need surgery? And what we're going to do tonight is introduce you to a new field of medicine and orthopedics, discuss roughly how that field works, what we treat, whether you're a good candidate for that. And then at the end, I am happy to stay as long as anybody has questions about the evening's presentation. So let's get started. In 2005, physicians for the first time on Earth began treating orthopedic conditions using precise stem cell injections. This is perhaps one of the first case studies on the use of stem cells. A 64-year-old male with a 20-year history of hip pain. He had very advanced hip osteoarthritis. He had two autologous, that's a fancy word meaning self. He had two bone marrow aspirate concentrate, BMC, injections 1 month apart. And this was the before and after. Before, this is the ball joint of the hip, and this is the cup of the hip. And you see that there really is no joint line here at all. It's bone on bone and looks very painful. After two bone marrow aspirate stem cell injections, you can see a joint line. That's the white space between the two bones. And a neocortical formation here with this black line on top of the femur. This was rather eye-opening, and it was the start of a new field of medicine. And this new specialty has come to be known as interventional orthopedics, which is an interesting term. What does that mean? Well, to explain interventional orthopedics, it's probably helpful to discuss traditional orthopedics. What is traditional orthopedics? Well, in traditional orthopedics, we use scalpels and drills and saws, a lot of tools, and we're in cutting and sizing, grinding, amputating. We're placing screws, plates, rods, nails, anchors, staples, and sutures. The metaphor here is one of carpentry. Now, in interventional orthopedics, otherwise known as regenerative orthopedics, which is a clue as to the difference here between traditional orthopedics and interventional orthopedics. The only tool we're really using is a needle, and we're placing it precisely using very advanced imaging. And this consists of fluoroscopy, which is real-time, X-ray, and ultrasound. And what we're injecting are our patient's own cells. These are human repair cells, and we'll get to those in a minute. We're placing them very precisely into areas of damage. And what we're trying to do is deliver growth factors to damaged tissues. The metaphor here is one of gardening. In traditional orthopedics, we are removing and rearranging tissues. We are deconstructing, reconstructing joints. We are replacing native structures. As opposed to interventional regenerative orthopedics, we are attempting to stimulate the repair and regrowth of tissue and to preserve native tissue and structures. And this is huge. Huge because the design of the human body has been refined for many, many millenniums in time. And with the exception of two or several, perhaps more than one, glaring design glitches, notably the prostate in men and the appendix in human beings, which is on the way out, by the way. Give us another millennium and it'll disappear altogether. The design of the human body is quite perfect. And whatever you do to change it, it comes at a cost. And a metaphor here might be trying to replace a factory-issued part with a cheaper replacement part. It'll work, sure, but it doesn't work quite as well, and it doesn't last quite as long. But keep that concept in mind. the preservation of native structures. That's important. So, what is the traditional treatment algorithm in orthopedics today? Well, it starts with an injury. And if it's bad enough, you take some rest and you do a little home triage. You put yourself on some ibuprofen. You may put ice on it, elevate it. And if you're lucky, that's all you need to do because you give it a day or two of rest and it begins to come around and it gets better. But if not, you go to the doc and the doctor will say, well, heck, let's go to physical therapy. I send you to physical therapy, and the majority of cases will improve with additional 2 to 4 weeks of physical therapy, and that's that, and you don't have to think about it again. But for those who try physical therapy and it hasn't worked, you're back to the doc, and the doc says, well, why don't you go see my friend, the orthopedic? And the orthopedic looks at you and says, well, you need a steroid injection. It's not getting better. Let's inject it with steroids. So you have the steroid injection. And, this typically works, and it works rather dramatically, but unfortunately, in many cases, it won't last. So a couple more weeks go by and you're back in the doctor's office. And this time he says, well, you know what? We need an MRI. And I'll tell you what, if you're standing in an orthopedic surgeon's office and you get an MRI, your chances of getting surgery go up about 90%. Surgeries tend to lead to more surgeries. And after a few years, maybe you have another one. More time goes by, you get out of shape, you put on some weight, the joint really begins to bother you, and you go back to the surgeon this time and he says, well, you know what? It's time to replace that joint. And that basically is the algorithm of treatment of joint pain in orthopedics as we know it today. So what's wrong with the algorithm? Well, let's start with steroid injections. Steroids are toxic. They are a doctor's trick that can make almost any pain go away, at least temporarily. But steroids are toxic. They kill everything they come in contact with. And the local anesthetics, lidocaine and bupivacaine, that we often inject with steroids are even more toxic than steroids. What they do is they kill the very cells inside of a joint that we're trying to keep healthy. And these include chondrocytes that are alive in cartilage, and includes fibrocytes alive in ligaments, and tenocytes and alive in tendons. It'll kill all of them and make them weaker. Here's a study that I want to call your attention to. It came out in 2017 in JAMA, the Journal of the American Medical Association. And it was a study where they, for knee pain, where they took patients and randomized them into 2 treatment arms. And one treatment arm got a steroid injection, a steroid known as triamcinolone acetate, 40 milligrams, which is a very standard dose, into their knee every 3 months for 2 years. And then the people in the placebo arm got an injection of normal saline, which is just a little bit of salty water, into their knees every 3 months for 2 years. And at the end of 2 years, they got MRIs. And what do you think they found? They found that the knees that were injected with steroids every 3 months for 2 years had a 50% cartilage loss compared to those that just had normal saline injected. The take-home point is that steroids are bad for your joint and they're not good for joint pain. But in my practice, if you've never had a steroid injection for a problem that a steroid injection is appropriate for, I will always give you a steroid injection. Why? Because that is part of the standard algorithm in orthopedics today. And in any orthopedic office in the country, you'll get a steroid injection. And in my office, you'll get one. But when you come back in 2 weeks, 2 months, or whenever it is, and you want another one, I will try to tell you about a better widget that I have. And we're getting to that. What's wrong with the current algorithm? Meniscectomy. Meniscectomy is otherwise known as the let's clean up the arthritis surgery. Again, talking about a knee, but this is applicable to other joints. This is where they go in and take out hunks of the meniscus, which you have on the inside of the knee and on the outside of the knee, the medial and lateral compartments. They provide a lot of cushioning to loading forces in the knee. They're very protective, but they get tears in them, and orthopedic surgeons are obsessed with these tears. And what they do is they go in and they begin to cut out enough meniscus until they can't see the tear anymore. And they say, hey, okay, you're good. But what unfortunately this does, without a doubt, is it increases your risk for arthritis. Stein did a study in 2010. He showed without a doubt that you have a 3 times increased risk 8 years after a meniscectomy surgery, which is minimally invasive. This is 3 ports into a knee. And why should that be the case? Well, it makes perfect sense. If you're taking out the big pillows inside a knee that cushion the loading forces, if you remove some of that, you're going to increase joint loading. And if you increase joint loading, eventually you're going to break down your knee much quicker than you would if you had intact pillows in these knees. What's wrong with the current algorithm? Knee ligament repair. This is the repair of the anterior cruciate ligament in the knee. And this shows a screw here and a screw down here. And this is typically it's a cadaveric, a dead man ligament, or it's a ligament harvested from another part of your body, typically the patellar tendon here. At any rate, this is a surgery that is effective in the short run, very effective. It gets professional athletes back on the field. Unfortunately, it doesn't get them back on the field for very long, because they have to sacrifice the native ligament. And the problem is that the angle of the native ligament, which is very, very shallow in the knee, can't be replicated. You have to drill in from the back of the femur and from the front of the tibia, and that changes the angle and makes it much steeper in the repair ligament. And we think that is what leads to arthritis. This is an article from the New York Times published in 2017, the title of which was, "If You Tear a Knee Ligament," and they were talking specifically about the ACL ligament, "arthritis is likely to follow in 10 years. They were quoting a Dr. Maninder Coker from Harvard. They noted that ACL repair rates were soaring in adolescent athletes, particularly young girls, ages of 15, 16, 17, were popping their ACL and undergoing this repair." And Coker, Dr. Coker, was quoted as saying 50% of these knees will develop arthritis within 10 years. Think of that. You're 16, you have an ACL repair, and at the age of 26, you have arthritis in your knee. That knee is shot. What are you going to do? We can't repair it. We can't replace it then. No doctor in their right mind would replace a joint in somebody that young. So what do? You have to live with it, is what you have to do. And the article ended with, "Will surgical techniques that more closely resemble native anatomy reduce risk of developing arthritis following surgery?" And the answer to that is you bet, you bet. Joint replacement. What's wrong with joint replacement? Well, particularly in the knees, it is not what it is cracked up to be. There is minimal functional improvement. One study that Harding did in 2014 showed that only 1 in 20, 5%, achieved normal activity levels following knee replacement. Many patients continue to complain of pain following knee replacement, and the numbers are as high as half, 52%. They have pain 3 to 5 years following a total knee replacement. The average pain level is 5 out of 10. According to Kahn, a published study in 2015. And finally, because this is metal, there's a risk of metal and material fragmentation, which can lead to toxic levels of foreign particles in the blood. So what is the promise of interventional orthopedics? Well, the promise is that interventional orthopedics uses the body's ability to heal itself. All we're doing is we're harvesting patient repair cells, we're concentrating them, and we're focusing them at sites of injuries. And if you place them very precisely, which is the art of this field of medicine, and just get out of the way, good things can happen. This is very minimally invasive. We're only talking needles through the skin. That's the term for that is percutaneous, across the skin. So what that does is it reduces or eliminates operative trauma. There is a minimal post-procedure recovery period, and there is a less painful rehab following the procedure. And the final result promises to be preservation of native tissues. Again, no need to alter or replicate nature's design, which no matter how well we do it, and we do it pretty well, actually, it's just not as good as Mother Nature. So this is a cartoon of the healthy balancing act inside any joint in the body. Your joint, and specifically I'm talking about your cartilage and the bone of that joint, It's constantly being remodeled, which means that it's constantly being broken down, degraded, and then built back up, repaired. These are fancy terms. These are some of the forces that degrade a joint. Catabolic. Catabolic is a fancy term for breaking down. The opposite of catabolism is anabolism, or anabolic forces. Anabolism means to build up. So the forces that degrade a joint are catabolic forces, and there's very pro-inflammatory forces. And let's be clear, this is chronic pro-inflammatory forces. But there's a balancing act in every joint of the body, and hopefully it stays balanced. But when things get out of whack, that's when arthritis begins to develop. So, what are some of the activities and lifestyles that degrade a joint or can potentially degrade a joint? Well, injury, first and foremost. And you need to remember that injury includes surgery. Surgery is a form of injury. It's a controlled form of injury, but nonetheless, it's an injury. Injury typically leads to instability. It can also disrupt the native tissues to the point where they remodel through scar tissue, which is never as good as the native tissue. And the end result is a knee or a joint that has been somewhat compromised. So injury is a big factor in forces that break down any joint. Obesity will break down a joint. Why? You're carrying extra weight. That increases loading forces, just like we were talking about earlier when you remove the meniscus. You increase loading forces, you increase wear and tear in a joint, it will break down quicker than a joint that isn't being so unduly loaded. Smoking, add this to the list of the many things, many bad things that smoking does, including kill you. The oxygen radicals in smoking actually just tear through any joint in the body. They destroy cartilage, they weaken ligaments, they weaken tendons, they leach density from bones. Not good. Smoking is another catabolic force. Poor diets lead to chronic inflammation, which is not healthy for any joint or for human beings in general. Poor fitness levels lead to instability, just as sedentary lifestyles do the same. Healthy joints require muscle and exercise to remain healthy. If 1, 2, 3, or 4 or more of these gang up on you, what happens is the balancing act here gets out of whack and it's tipped towards the side of degradation in the joint. So what are we doing in interventional orthopedics to counter this? And specifically, that's what we're doing in interventional orthopedics. We're countering catabolic forces and pro-inflammatory forces. And what we're doing is that we're using anti-catabolic forces. We're countering breakdown. How are we doing that? Well, this is a background picture of beautiful red blood cells. Not red blood cells. That's not what we're using. What we're using is another portion of blood known as the serum. And in the serum, in the past, I'd say 15 years, so very recent history in terms of medicine and in terms of human civilization, we've discovered chemicals in human serum, all human serum, that counteract pro-inflammatory environment and inhibit MMPs and peptidases. What is that? What are those? MMPs and peptidases. These are enzymes, and these are destructive enzymes, and they're alive in any joint in your body. And this is how the joint is broken down. In other words, this is part of remodeling. MMPs and peptidases digest bone and cartilage before your chondrocytes secrete more collagen to repair and build back up cartilage and bone. What happens in an arthritic knee is that metalloproteinases, MMPs, that stands for matrix metalloproteinase, and peptidases, these enzymes become predominant in their activity, and nothing is countering them. And what they're doing is simply destroying the cartilage and the bone of your joint, very slowly over time. And human serum has these substances, some of which are listed here, that counteract, that neutralize these MMPs and peptidases. And some of these substances are known as interleukin receptor antagonist protein, otherwise known as IRAP. IRAP binds to a very pro-inflammatory chemical known as interleukin-1 and neutralizes it and reduces the inflammatory environment inside a degenerated joint. Alpha-2 macroglobulin, A2M, This is an inhibitor of one of these matrix metalloproteinases. Not one of them, many of them. It's a whole class of enzymes that are inhibited by this substance. There's another one down here, TIMP. I just didn't type it out. This is tissue inhibitor of metalloproteinases. Again, just like A2M. All of these are found in human serum. So if you did nothing but take human serum and inject it into a joint, you're doing a good thing for that joint if it's arthritic or otherwise painful. What else do we do? Well, we seek out anabolic factors. These are factors that build up a joint. What are we talking about here? Well, in a word, we're talking growth hormones. Growth hormones are powerful cell signaling molecules. They are contained inside human repair cells, which we're getting to in a minute. Growth hormones promote cell division and cell growth. They increase vasculature. This is a very important concept. They increase the blood supply to tissues. And any tissue will only repair itself insofar as it has a blood supply. So that's a very important concept. Growth hormone stimulates protein and matrix secretion. Some examples of growth hormones are PDGF, which is platelet-derived growth factor. FGF is fibroblast growth factor. VEGF, vascular endothelial growth factor. Which brings us to where do we find these factors, the anabolic factors and the anti-catabolic factors. We find them in our patient's repair tissues, autologous. There's that word again. It means self. So in our patient's own repair tissues, that's where we find these factors. And we call them orthobiologics. Why? Because we're using a patient's biological tissue to treat orthopedic injuries. Hence the term orthobiologics. Repair cells in the human body come in two flavors. One is a small circulating blood cell known as a platelet. So you may have heard of platelet-rich plasma. That's a very effective repair preparation of human repair tissue. The other one, and it's more powerful, is an adult stem cell. And in my world, we find human adult stem cells in the bone marrow. Can you find them in other tissues in the body? You bet you can. But bone marrow stem cells have a particular propensity to turn into the cells of tissue of orthopedic interest. That includes cartilage, ligaments, tendons, and bone. So that's why we use bone marrow. So let's go back to this healthy balancing act. Say you walk into my office and you're a middle-aged person, you've got early arthritis. It's not bad at all, but suddenly the knee's aching, it's swelling on you, and you've had that steroid injection rather. It worked great for about 2.5 weeks. And then you're right back to where you started and you heard about something we do in my office that's better than steroids. Or say you're a young athlete, you're a thrower, and the coach kind of made you pitch 3 games back to back, and now your arm is hanging by a thread, and you're in a lot of pain in that shoulder, and you really can't throw, and we get an MRI, and guess what? You've got a small tear in your rotator cuff. I'll look at your films and work you up, and I'll decide, well, hey, you know what? I think I can handle this with a little PRP, platelet-rich plasma. So we do that. We do a PRP injection. What do we get with a PRP injection? Well, we get a whole host of anti-catabolic forces. Those forces we just talked about. Alpha-2 macroglobulin, it's a peptidase inhibitor. IRAP, it's a pro-inflammatory substance. We get TGF-beta, another peptidase inhibitor, as well as tissue inhibitor of metalloproteinase. So a lot of anti-catabolic factors. And we get also anabolic factors, notably platelet-derived growth factor, a very powerful growth factor. But let's say you're a little older and that arthritis is more severe, or you're the same thrower, but you're unlucky enough to have actually a full thickness tear in your rotator cuff, or you're a female basketball player and you stopped too suddenly and you popped your ACL. I'm going to look at this and go, yeah, platelets are not going to be sufficient here. I need to use stem cells. MSC stands for mesenchymal, adult mesenchymal stem cell. What do we get when we inject stem cells? we get a whole host of anabolic factors, VEGF, FGF, IGF, CXCL. And by doing this, what we are doing as physicians is we're putting our finger on the scale over here, and we're trying to tip the balance towards repair and preservation of native tissues and healthy tissues. So let's return now to the algorithm, and let's discuss it again in light of interventional orthopedics. The algorithm remains almost exactly the same up until the point of the MRI. If you're standing in my office and we are looking at an MRI of a joint in your body that isn't responding to conservative care, I may say, hey, let's try PRP or let's try stem cells. And we do that regenerative orthopedic orthobiologic injection. I send you back to rehabilitation. And when we're successful, you come walking back in my office 8 to 12 weeks later with a big smile on your face saying, oh, it's so much better. It's so much better. And what we have done is we have preserved those tissues. We've made them healthy again so that they don't bug you and they're not causing you pain. And look what we've done. We've actually taken you out of this algorithm that pushes you inexorably towards joint replacement. We've done a U-turn out here. We perform precise image-guided stem cell and platelet procedures to treat headaches, neck pain, upper back pain, shoulder arthritis, shoulder rotator cuff tears, shoulder labral tears, wrist, triangular fibrocartilage, thumb and wrist and elbow arthritis, low back pain, sciatica, facet syndrome, disc herniations, bulges, and lumbar spinal stenosis. We treat hip arthritis and hip labral tears. We treat knee arthritis, knee meniscal tears, knee ACL tears, and we treat ankle arthritis. Let's discuss some examples of interventional orthopedics. This is a typical setup in the procedure suite in my office. This is a knee fully surgically draped. And this is a fluoroscopic camera, and this is the image of that knee being taken at this moment by the camera. This is an MRI image of this knee, and this shows us why we're treating it. This is the kneecap, otherwise known as the patella, and this is the end of your thigh bone. And if you look, you can see this gray kind of motley looking thing here. This is the cartilage, and it's suffering from what we call chondromalacia. It's softening. And we know that it's softening and not competent. Why? Because there is this signal inside the gray bone which shouldn't be there. That high white signal means that's bone edema. That's bone swelling. That is swelling bone that is very painful because the cartilage has become incompetent. So we have to treat the cartilage and we have to treat the bone. And that's what this picture is showing you. This is a trocar that has been worked into the kneecap bone. It is inside the bone. We are about to inject stem cells into the kneecap. This is a very fine needle that is through the knee joint capsule, which you can see faintly right here. And it's injecting dye. And you can see that dye is flowing nicely over the cartilage behind the kneecap. And here we're also going to inject stem cells. But this is the elaborate setup that's required to do this type of work. And it's very precise, as you see. And it requires very advanced imaging to do this. Here's another picture. This is an injection of a shoulder. It shows 2 placements of the needle in real time under fluoroscopy. This is what a fluoro looks like. So you see it looks like an X-ray, but it's real time. I can keep my foot on the pedal and I can watch the needle move as I place it. The first placement here with this arc of dye is injection into the glenohumeral joint, which is the main joint of the shoulder. The second placement causes this little triangular formation of dye. That little triangle is your shoulder labrum seen on edge. And what we're treating is a superior labral detachment. It's a superior labral tear, otherwise known as a slap lesion. So you see the precision that's required. And here's more precision that's required. This is a hydrodissection of the median nerve, and this is under ultrasound, so this is a different imaging modality. You can see the needle come in. This is a very fine needle. It is a 27 gauge needle for those of you who know gauges and needle. Very, very thin. This is the size of a pea. This will give you a scale of the delicacy of this type of work. Why will interventional orthopedics replace elective orthopedic surgery? Because number one, it's less invasive. Number two, there's a quicker recovery. And number three, the promise is that we will preserve your native tissue. We won't have to alter them. And that joint or tissue will be much the better for it. Oh, we're going to pause here just for, wow, yeah, it's really late. I'm sorry, I've been very slow this evening. I have a bunch more here, which am I going to get to tonight? I don't know. I'm surprised that I've gone so long. So I think I'm going to end it here and take any questions that you may have. This was a lot of discussion about candidacy. In other words, who's a good candidate? And really, that's only determined by what I find upon exam and what your films show me, and a whole host of other factors. But that's basically what we do, is we put you into three categories: good, fair, and poor. And if you're a poor candidate, I will tell you you're a poor candidate. And what that means is I'm basically saying to you, I think you have a less than a 3 out of 10 chance of success, and that you should probably have surgery to treat the condition that you're complaining about. A 30,000-foot view, just to wrap up here, is that we're able to treat many patients with severe arthritis and help them avoid knee replacements. We're able to treat mild arthritis and prevent it from getting worse. And we can treat meniscal tears. We're able to help many patients with severe shoulder arthritis avoid a joint replacement. We can repair rotator cuffs without surgery. We can repair shoulder labral tears without surgery. We're able to help many patients with chronic back and leg pain, other knee or joint ligament tears. Just a word of caution on stem cell hype. There are 3 phases of procedural adoption. So in other words, a new procedure comes down the pike and you start using it. And the first phase is, wow, this is magic. It helps everybody. You do it for a while longer and you change that. The expression now becomes, well, hey, this is great, but it helps almost everybody. And then finally, after you do it a few more years, you say, hey, let's figure out who's a good candidate, which is what we do in my office, as I just explained to you. But my office is among the very few practices doing this that is in phase 3, trying to figure out who's a good candidate. Everyone else in this space is still pretending that this is magic, and that's a rabbit coming out of a hat. One of the biggest frauds in this field is amniotic, placental, or cord stem cell injections. This is fraud. It's not legal, it's dangerous. Basically, what they're doing is injecting vials of stuff that are obtained out of the back doors of OBGYN clinics. Laboratories have tested this stuff. It shows them to be dead tissues. They have been radiated to make sure that there is no living cell inside it. So what's going on here? Inside that vial, there are a few growth factors. So if you do it, inject it into a tissue or a joint, yeah, it can be helpful. But I'll tell you what, the concentration of those growth factors and cytokines pale in comparison to what a trained physician can get from a living patient sitting opposite them. The other thing is that these are often performed in chiropractic offices. They're not using any guidance when they're injecting these things. The injection is done by a physician assistant or a nurse because the chiropractor by law can't do injections. You won't find a doctor anywhere inside the clinic. These are dead cell products. And what they're charging you is often 2 to 3 times what a patient in my office would get charged. And I'm a medical doctor, and I've trained over 10 years doing this type of work. Thank you so much for your patience. I did run way over time tonight. I usually pride myself coming in well under an hour. So I was very dilatory this evening, and I apologize for taking up so much of your time. I'm happy to answer any questions anybody may have. So just type them in, and I'll answer them. I'll go through them quickly as they come in. What I left out was an in-depth discussion of the candidacy ratings and what are some of the visual imaging criteria for what we consider good candidates, et cetera, et cetera. We place you into three categories: good, fair, and poor. The good category, if you're in that category, we think you have a better than 6 out of 10 chance of success. And success, by the way, we define by the goals of our patients. I'll often have patients come into the office and say, "Doc, I can't walk the golf course anymore. I have to use a cart. I really want to get back to walking 18." So for that patient, that would be a success. When I treat them, they're back walking the golf course. So that's what we consider a success. It's determined by our patients. And if you're in the good category, we think that every 10 times we try to treat somebody like yourself, we think that at least 6 out of 10 times we will be successful, which are pretty good odds. If you fall into the fair category, you drop down to 30 to 60% chance of success. And what that means is somewhere between 3 and 6 times out of every 10 times we try, we'll hit success. If you fall into the poor category, what that says is for every 10 times we try to treat somebody in that category, less than 3 times do we think we will be successful. And yet, I have a presentation where I do people in every category, every joint category, shoulder, knee, hip, spine, that fell into the poor category. We went ahead and treated them in any case, and they ended up having a good outcome. So, despite the odds, they persisted and they did well. Looks like we have some questions. Let me get started with them. Are you awake for the procedures? Yes, you are awake for the procedures. You are sedated on the table with an MKO melt. This is something that we give you under your tongue. We anesthetize the skin so that the pinches of the needle entering the skin are very dulled, if not completely absent from your perception. But you do feel, and you will interpret the sensation of the needle in the deeper subcutaneous tissues, which is not painful. Some treatments that we do are painful, including bone augmentation. And it's at that point that we will do a particular focal nerve block. If we're treating the knee and doing bone aug in the knee, for example, I'll block the genicular nerves. It's important that you be awake because often I have to have you move. I need your cooperation to place the needle precisely to hit the tissues and the targets I'm after. A question from Stephen: is a complex tear of the medial meniscus a procedure you would treat with stem cells? That totally depends, and it requires examination, Stephen. Like I said earlier, the orthopedic surgeons are obsessed with meniscal tears. Depending on your age, I will often even ignore tears in meniscus if I am certain that your pain is coming from elsewhere. So yes, we treat complex tears if we have to, and we often do. But that doesn't necessarily mean that's the source of your pain. Again, it depends on what your imaging shows, how old you are, and what my examination tells me. Another question from Stephen. Also, is there adequate blood supply for the cells in the posterior horn body of the medial meniscus? Well, this is an anatomy lecture, Stephen, and no, part of the problem is that most orthopedic tissues of interest, meniscus, cartilage, articular cartilage, ligaments, tendons, and bone, all have a poor blood supply. That's why we have to do this work. And that's my job. My job is to bring the blood to the area that doesn't have enough blood. And quite literally, That's the bottom line. If I can get the stem cells and the repair cells into the area of damage, good things can happen. Yes. Another question from Anonymous. Can your treatments work if you are missing an entire meniscus removed 40 years ago? Yes. Yes, they can help. Can we regrow your meniscus? No, we cannot do that. But again, it depends on your age, what the imaging tells me, what my examination tells me. And again, if I don't think you're a good candidate, folks, I will tell you, because you are paying me for my expertise, and my expertise is hard won, and I wield it with confidence. I will tell you if I don't think you're a good candidate for what I do. What about insurance coverage? In my office, we will treat you under your insurance up until the point we decide to do a repair cell procedure. So in other words, you walk into my office, and this is a common scenario. Most people who walk into my office who don't really know me and haven't searched for me, they don't know what I do. And I will treat them like any orthopedic in the country would treat them. And that includes a steroid injection. If you need a steroid injection, I'll do that. If you need an MRI, I'll get that. And we will do all of that under your insurance. When the standard orthopedic treatment stops working, that's when I will talk to you about stem cells, platelets, repair cells, and doing a procedure with me that your insurance will not cover, that will cost you money. How it works in my office is, once we get to that point, I send you via email a proposal which lists line items of what I'm going to do to your joint and what it's going to cost you. Always, 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 you need to remember, I am a medical doctor. I am not a used car salesman. I never want to be accused of point of sale pressure. We do not twist people's arms. If it gets to the point where you get a proposal from me, you receive that proposal in private and you consider it. And if you have questions, you are encouraged to call my administrator and say, hey, I need to speak to Dr. Sutherland. I have a few questions. Because you have to be happy with what you're about to do. But does insurance routinely cover these procedures? No, they do not. Not yet, not in time, but they will. Why do I say that? I say that because insurances are all about money and the bottom line. A stem cell procedure is a fraction of the cost of joint replacement, fraction of the cost. And when insurances finally get around to looking at the data, they will say, hey, we're going to start covering this. It's going to save us a lot of money. They haven't done that yet. They haven't gotten there yet. And there's many, many, many reasons for that. That's a long discussion. Another question. Can PRP stop or slow the progression of arthritis? You bet it can. You bet it can. All repair cell treatment that we're talked about this evening can slow down the progression of arthritis dramatically. Is it a cure for arthritis? No, that remains the holy grail of orthopedics. How do you cure arthritis? When you finally find a cure for arthritis, human beings will begin to live routinely 150, 200 years. It hasn't happened yet. My MRI, Stephen here again, my MRI also shows arthritis on a knee. Can this as well as a meniscus issue be tackled at the same time? Absolutely. Absolutely. That's why when you come in my office, it's basically I'm telling myself a clinical story. I'm looking at getting you the best diagnosis, and then I am developing a list of what needs to be treated. What do I have to address in this joint? And quite often it's extensive, as you will see if you come into my office. A question from Pam. How is the stem cell retrieved? The stem cell is retrieved from two large bones in your pelvis, in your back. They're known as the iliac crest. They're very thick. There's a lot of marrow there. I mean, I can get marrow out of any bone in your body. We go there because there's a lot of marrow. And there's no major nerves or blood vessels we have to worry about. This is a common question from all patients when they are told that we have to go into their bone marrow to get their stem cells. Oh my gosh, that sounds horrible. I know it sounds horrible, and the reason why it sounds horrible is because there are stories out there of people who've had doctors, usually oncologists, go into bone marrow to rule out cancers of the blood. And oncologists know how to get marrow, but they're not trained how to get it painlessly. Well, we are, And the first 15 minutes of a bone marrow procedure, when we're retrieving stem cells from the bone marrow, we spend numbing you up. And the key to numbing you up is numbing the skin, numbing the deeper subcutaneous tissues, and then very importantly, numbing the cortical bone. You have to numb the cortical bone. If you do that, then you can drill into the bone and it doesn't hurt. And I know people look at me very skeptically, but personally, I've had it done 3 times, and literally I've done it probably approaching 600 to 1,000 times in patients, and nobody complains. I see very few people complain. It's not painful. That's not the painful part. Any more questions? Stephen with another question. You took stem cells from me a bit over a year ago for my thumbs. Can I go back into the marrow for more stem cells? Of course you can. When we take marrow out, your body replenishes that bone marrow in anywhere from 2 to 4 weeks. So the minimum turnaround time on doing multiple stem cell procedures in the same patient is 4 weeks. Any more questions from anybody? I really appreciate people coming out and spending so much time. Again, my apologies for going so slow. I don't know, maybe I'm low energy this evening. I hope it wasn't, I hope the presentation didn't drag. Pam has another question. Is the stem cell and the procedure are completed at the same time, and what is the recovery? Okay, good question, Pam. Stem cell, depending on the joint that we're treating, in any peripheral joint in the body, stem cell is a 3-step procedure. And we use a Monday, Wednesday, Friday schema. It doesn't have to be done Monday, Wednesday, and Friday, but it's 3 distinct steps with a day or 2, or sometimes a little bit more in between each step. The spine is different. If we're treating your spine, it's a 1-day procedure, in and out. With any other joint, it's a pre-injection, which is basically sugar water, dextrose, 12.5%. It's very irritating. And what that does is it sets off some inflammation inside the joint. Why is that important? Aren't we trying to treat inflammation? You need to remember that the body repairs itself through acute inflammation. This is as opposed to chronic inflammation, which is going to kill us all. Acute inflammation is how the body repairs itself. So when I put stem cells into a joint that is inflamed, that is a biologic cue to the stem cell that something is wrong and it needs to be repaired now. So it's important that we have a little bit of inflammation in the joint. So that's what the pre-injection on Monday is all about. And it's just a very quick injection. It takes 5 minutes. You come in, ultrasound, sterilization, ultrasound, needle, inject, done. And you're good to go. 2 days later is the big day. It's called the same-day procedure. We take about 45 minutes to harvest bone marrow. It takes us about an hour, a little bit more, to extract all the cells from the bone marrow and concentrate them. And then depending on what we're doing, it'll take me an hour, sometimes more, to put them back into your joint or your spine or your neck, whatever. So that's the long day, and you're there for, in my clinic, about 4 hours. 2 days later, you come back, and what we're doing is the post-injection. At this injection, what we're doing is we're feeding stem cells. What are we feeding them with? Your platelets. We're doing a platelet-rich plasma injection. We cannulate a vein in your arm, we get some blood, we spin the blood, capture the platelets, concentrate them, and very quickly just go back in. And it's a general it depends on what I've treated with the bone marrow. It really does depend. But typically, I'm not doing a lot of injecting that day. I'm just administering platelets in 2 different forms, your platelets in 2 different forms, to support the stem cell activity of the stem cells we put in 2 days earlier. So it's a 3-step process. Pam, I hope that answers your question. Pam has one question. Can this presentation be viewed anywhere? If you signed up for it, you'll get a link, and yeah, you can look at it anytime if that's what you're asking. There was a lot of information tonight. Yeah, it was, and I'm sorry I went on so long. Here's another question. If we live out of your area, is it better if we see another orthopedist first so we have already tried rehab, or can we start with you? You can absolutely start with me. It depends on what you're looking for. If you want to be treated solely like any other orthopedic in the country would treat you, I'm happy to do that to start. Yeah, no problem. And we do that because often just going to physical therapy is sufficient. So if you haven't been to physical therapy yet, yeah, go to a local orthopedist. But I gotta tell you, your local orthopedist is not very interested in physical therapy. Your local orthopedist is interested in surgery. So don't go to your orthopedist. Go to a local physiatrist or go to a local internal medicine doc who has a special interest in, musculoskeletal medicine. Or just walk into a physical therapist's office and then call your internist and say, I need a prescription for physical therapy, and see if they just give you one. But try physical therapy, absolutely, because everything that we do in this office requires physical therapy in the recovery period. And it's a standard part of the algorithms we discussed earlier this evening. Whether you're going to go on to surgery or you're going to do a orthobiologic injection with me, you always do physical therapy. You always try that first. Of course, that's a tried and true in medicine. You do something less invasive before you do something more invasive. So you don't, twist an ankle mildly and, start talking about surgery, heaven forbid, or even sticking needles through your skin and injecting your blood into that ligament. You can, and actually what I do, sticking a needle through your skin and injecting platelets can be a smart thing to do when you've got a ligament sprain. But that's not the first thing you typically think of, physical therapy. So yeah, get yourself a script of physical therapy. That would be helpful. Well, I want to thank everybody for coming out this evening. And I'm happy to talk and answer more questions in my office. So if you're inclined, please, it'd be my pleasure to evaluate you and give you an opinion on whether I think I can help you with orthobiologics. Thanks once again, everybody, for coming out. Take care, be safe, and good luck.